seconds. Guess it's making noise. Yep. Okay, let's see. And again, like I said, I'll just unplug my mic here so don't get freaked out. I'll plug it back in once I mute it.
Okay.
I'm looking at the wrong thing. Okay, here we go. In 5, 4, 3.
Hello, everyone. We're ready for our student webinar number 47. Got a great topic for you tonight. I've got this on my brain, and I always like for us to talk about going back to the basics because that's what we do as students, right? We're learning the basics. We get a lot of questions about the different types of coding, and one of the questions that we get is about ProFee coding. Now, I don't have as much experience in ProFee coding, and it shows. So, if anybody asks about different types of coding, I always want to talk about risk adjustment and diagnoses and auditing and compliance. And I want to talk about, document specialty work, things like that, because that's what I'm passionate about. That's what I enjoy, and that's what I've done in the past. However, a huge market of what coders do is ProFee coding. And so I wanted to kind of explain that. Some things that have been brought to my attention recently about ProFee coding. And, when we're out there as instructors and this stuff like this cross our paths, then we're like, oh yeah, we gotta let somebody know about that, or that's a great topic to teach on. And I got all these little ideas and notes for things that I want to tell you about. So let's talk about what ProFee coding is. And most of the information that I got tonight, I have a link at the end of the resource slide. So if you're in the CCO club or one of our students, you'll be able to have access to those links. If you're just visiting us on Facebook, YouTube, or LinkedIn, then you can always go join the CCO club and be able to get the slide deck. In the meantime, as we go back to what ProFee coding is, it's considered professional coding, and everything else, well, not everything, but you divide it up kind of in two categories. You have professional coding, and then you have facility coding. So when we say professional coding, we are usually referring to things that the individual physician is doing, not what a facility is doing, what type of procedures, inpatient stays, things like that are being done in a facility. It's being done by the individual provider as a professional coding. So facility coding, again, you would have sometimes you have ERs in facility, but same-day surgery, you've got the OR, the OB department. Whenever anybody is doing an observation or inpatient stay in a facility, those are being coded based on the facility being reimbursed, not the provider alone. Now, when we talk about professional coding, we're talking about family practice. Now, the family practice could still be part of a clinic system for a hospital. However, it's separated. So if you talk to somebody and you know that they work for a big hospital system, let's say Baylor Scott and White's a big one here in Texas. So they say, well, I work for Baylor Scott and White as a coder. And they then they'll clarify and say, well, no, I'm on the clinic side, or I'm on the hospital side, or the facility side, but usually I hear them say hospital side. And that's what they mean. If they're facility side or hospital side, that means that they're coding for inpatient stays and things like that, stuff that's being billed by the hospital, the facility. Whereas if you're on the clinic side, that would be the doctor's billing, and they still would be hired by the hospital system, but they're hired through the clinic system, like a subset of the hospital system, and their codes are different. They use different code sets, whereas inpatient's going to use ICD and PCS and HCPCS codes, you know, too sometimes, but the outpatient or the clinics side of everything is going to be using CPT codes, HCPCS codes, ICD codes, not any PCS codes, but the modifiers are also different. So we'll talk a little bit about the modifiers. Evaluation and management is very heavy in ProFee. It's a large part of what you learn. Now, for CCO, how we divide that up in the courses that we teach, we call it physician-based coding for the professional or clinic side. And then for the inpatient side, we call it inpatient, but we also have facility-based, which is, excuse me, things like the COC or even the CCSP. There's kind of three subsets where we divide it up a little bit, and that's because of the code sets that you'll learn, the ICD, the CPT, the PCS, so on and so forth, and the modifiers too. We want to make sure that you get everything you need for the credential that you're wanting to sit for. Okay, so the verbiage that we use might be a little bit different. So the professional, I mentioned family practice, but this is all of your specialists too. This would be the cardiologist, the ENT, the podiatrist, the endocrinologist, gastroenterology, cardiac thoracic surgery. All of these pediatricians, they would be considered ProFee or professional coding. So they're reimbursed based on their profession is the way I like to think about it. And again, they're using CPT codes and E&M codes that are through the CPT code set. Now, if you go back to what CMS states, is that there's a main difference. The professional coding is based off CMS, and facility coding is facility based, kind of what I've already said. But CMS has a lot to say about that. And CMS is the one who states that for professional coding, we have to use the CPT code set. The E&M for ProFee is going to be based on two sets of guidelines. You've got the 95 and the 97 guidelines. Now, we've done webinars before on the differences between 95 and 97 guidelines. Whenever you do specialty work and you're going to do, you know, ProFee, a lot of times they'll use the 97 guidelines because it is based on the exam that's being done, and so it works really well for specialties. And here it mentions podiatry, OBGYN, or even like ENT, but a lot of times you'll find that when you go to sit for an interview, they'll say, do you know 95 and 97 guidelines? And if it's a professional coding, a ProFee job, they'll say, you know, most of the time they say we use 97 guidelines. And so again, you can go in and look in the club. We even probably have a little bit of some videos about the guidelines 95 and 97 in our YouTube channel if you want to go jump out there and look at them. Emergency rooms, though, like to usually use 95 guidelines because of the way the exam is set up in the evaluation and management. They've got like bullet systems and stuff. And if you're just new to your coding course, of course, you'll be learning about these guidelines. I've got, here is one that I printed out, an E&M audit form, which I don't know if you could see that just real quick. It's really, really tiny. But again, this is one that I was looking at, 2 pages. And what usually happens is if you find one that you really, really like, and And CCO has a great one that Laureen created several years ago that is still applicable. It's that good, you know, plus they don't really change that much, but she created a fabulous one that's really easy to follow. And when I came across it for the first time is when I was teaching at the college, and everybody was not understanding E&M, and everything I was telling them, it wasn't clicking for them. And that's one of the ways I found Laureen. And she had this great E&M tool. This is not it. This is just one I was wanting to look at. And then I started having them watch the webinars that Laureen was doing, where she was answering questions that people had asked and things. And so find an E&M tool that works for you. A lot of people will laminate it so they can use like a dry erase marker on it, and then you just wipe it off, or they'll put it in a sleeve and then have it nice and clean, and then they can keep using it. But again, 95 guidelines, a lot of times emergency rooms, because they are different. Now, that's kind of the basics about ProFee, but there's other things that you need to know. The ProFee is, again, E&M driven, so that's why we have these great E&M tools. It's not something that you can do in your head. Now, if you work just for if you work just for one provider, and let's say you do cardiology and that's all you do, and it's for one provider, and you know you can get to where you can click off those bullets in your head, you know, and stuff. But if you're doing multi-specialty, multi-providers, you know, you really need a good E&M tool there at your desk to be able to reference and check those off, because you know, one or two bullets in the not in the right place can lower you know, make a 4 a 3 or a 5 a 4. And again, if this is new to you, you're probably just learning this in your course. It's fun stuff. It's very exciting. And I want to reiterate too that you know, this is what coders do. This is, you know, the providers are not really taught how to level the E&M. They're educated about it a little bit, but they rely on us to be that liaison for them. Our job is to translate what they've documented into the code set, you know, and that's why we are coders. It's like a translating a language for them. And so but the way we do that is based on the documentation that we're given, and then again we divide that up, and then we know that you've got all of these components, so it meets a level 4, or it meets a level 5, or etc. And then with E&M, new and established patients, different leveling for each of those. The criteria for them are a little bit different. But once you get it in your head, right, you're good to go. Some people absolutely love the E&M component of coding, and some people don't like it. Now, I am a fan of, I like E&M, but it's because of the medical decision making, because that's what you know, it really weighs heavily on the diagnosis and the disease process, whereas the other components are based on the physical and the H&P. You know, how many body systems are we looking at, et cetera, et cetera. And you will be learning all of that in your course. Now, I'd love to have you comment that, let us know in the comments if you love E&M, or if it's something that you don't enjoy as much as other areas of coding. And let us know if you're new to coding, if you're a student, and what helped you get through the E&M portion of your courses. I'd love to hear that, especially if you use some of the CCO tools, because I think they're brilliant. So let's talk about how the E&M level is driven. I mentioned the H&P, we have the exam, and then we have the medical decision making. When you look at an E&M code, it tells you for a new patient, you have to have 3 of the 3 components, okay? And that would be the 3 that I mentioned. But for an established patient, you only have to have 2 of the 3. Now, I always look at the medical decision making because, again, that's a part that I really enjoy. But if the medical decision making on an established patient is low, but the HPI and the exam are really heavy, it's really detailed, then it can maintain a higher level in the E&M because you have to meet or exceed. Okay, and you have to have 2 or 3. Whereas if you're doing the E&M for a new patient, this kind of makes sense. If you have a new patient that the provider's never seen before, and they're talking to the patient, and they're learning about the patient, and they're doing, reviewing the medical history, they're reviewing the medications that the patient is on, which would be medical decision making. Maybe they've moved from one state to another, and they're setting up a whole new. They want new providers. Maybe they have diabetes, and so they need to get in with an endocrinologist and stuff. And it's the PCP. The person is establishing care for their PCP. A new patient with a chronic condition, one chronic condition for something like diabetes that affects all the body systems, that could be a pretty heavy E&M, a higher level because of that. However, if you have that same another person, like mirror that person, and let's say they have one chronic condition too, but it's not the same chronic condition. Let's say they're the same age, they are establishing care, and they have moved from out of state, and their one chronic condition is osteoporosis. So the medical decision making is going to be at a higher level probably for, and the review of systems and everything is going to be higher for your person that has the one chronic condition of diabetes than osteoporosis, because osteoporosis really affects one body system. And so you can see how that medical decision making plays a part where everything else kind of fits into place, and you're like, well, they the history and is not going to be as intense with a patient that has just osteoporosis, or the review of systems, right? The exam versus a patient that has diabetes and has medication managements for that. It's important to know the number of possible diagnoses and or number of management options. Again, that was just what I was giving an example of: patient with osteoporosis and a patient with diabetes. Much more intense, especially if you have the patient with diabetes is on insulin. They're a type 2 diabetic on insulin with a family history of diabetes, and then you have a patient with osteoporosis, and they are eating Tums, and they're giving themselves a shot, or they're getting the shot that they one of the new shots, but that's it. The amount and or complexity of the medical records and diagnostic tests. So let's say our osteoporosis patient hasn't had a DEXA scan in a long time, and so the provider says, let's go ahead and do that, and let's do some lab work. And then, but with your diabetic patient, the complexity and the amount of tests will be higher. Let's do an A1C, right? A hemoglobin A1C. Let's do a lot of other tests to see how your other organs are functioning, because diabetes affects all organ systems, even your skin, right? So the kidneys, the eyes, the heart, they're going to be checking all kinds of levels for the blood, as well as if you say, well, I haven't I haven't been to the doctor in a while before I moved. That's why I knew it was important to establish care, because I relocated. And he says, you know, we're going to need to do some diagnostic tests because I'm listening to your heart and I'm hearing something a little odd. And I want to, let's just make sure that, you know, you haven't developed some AFib or some other things that can cause the diabetes can affect, right? Peripheral neuropathy, circulation problems, you know, so a lot of diagnostic tests, and the records that come from a previous provider for diabetes is going to be a lot more than osteoporosis too, that the doctor has to go through. The risk of significant complications and morbidity. Well, osteoporosis can be severe, and that means that you could have a pathological fracture. And if you have osteoporosis severely in your neck, or you have it in your hip, and you're at a fall risk, absolutely significant complications can be involved, but not like a person with type 2 diabetes that's on insulin. Okay, significant complications if you're suspecting that the patient has, you know, peripheral neuropathy and circulation problems already, then the chances of them getting you know, having problems with their feet, you know, do they need to go see a podiatrist? Who is doing their nails? Are they doing their own nails? And if they're not doing their own nails, you need to check their feet, right? And see if they're getting ingrown toenails or even like a fungus or something, you know, in those toenails, because one, or properly fitting shoes. Is there any, you know, sore spots on the feet that could turn into gangrene? Because the morbidity and then mortality would be higher for a diabetic patient than it would be for a patient that has osteoporosis. Let's go look at some questions real quick. Whitney says, I used to not like E&M, but now that I've been doing it for a little while, oh, wait just a second. It moved on me. Oh, they're coming through. I apologize. Let me just move that up real quick. Let's see. I've been doing it for a little while. It's not bad as long as the documentation is good. I deal with the same providers who could give you a headache. Yeah. But when you deal with the same providers over and over again, it also, I think, becomes a little bit easier. You get used to where they document the information and everything. But yeah, they can sometimes code for a level 4 when it's really a level 3, or code for a level 5 when it's really a level 4. And then let's see, another one that came in. Let's just check this. Whitney said, time is a component of some codes too, so you have to keep that in mind. How to get used to that? Absolutely. If the provider, it's not E&M, but if a provider counsels and talks to the patient about cessation of smoking, to stop smoking, they could have a beautiful documentation about everything that they talked to and went over, a whole paragraph. But if they do not document that they, you know, how many minutes, because between 3 and 10 minutes is one code and over 10 minutes is another code, they don't get to use that code, because it's time-based, and if the time is not documented, they don't get to use it. Let's see. Oh, Whitney also asked about R99. We'll go look at that. I have to look it up because I don't even remember what that is. The big debate I've had with the providers is, just because the patient was given morphine, does that automatically make it a level 5? Well, no, because and morphine is something that, you know, you definitely have to regulate. But if it doesn't have the all the components, now if it's an established patient, you know, you only need 2 of the 3 components, and medical decision making can be high. However, if a person is you don't have the history and you don't have the exam portions of it, just because they gave morphine, it's not, you know, we need to know why they gave morphine. You know, what constituted that? What body systems did you have to look at? How thorough was the exam? What's the history of the patient? Why are they taking morphine versus another medication? What other medications have they tried, etc. Yeah. Catherine says, when you take your online classes, is ECNM part of the study or you pay for it separate? No, when it should be included. That especially if you're doing a general code, ProFee coding or physician-based coding, it's absolutely a part of what you'll be doing. And there's E&M components of inpatient coding too, that, you know, consults, initial and subsequent consults and stuff. So yes, it should be included depending on how you're getting your education, how they divide it up. Maybe they have you pay for just components that you need of courses or modules that you need. But, you know, we at CCO give you everything in the physician-based coding course that you need to be able to get the credential. Let's see, perhaps, let's see. Okay. And again, different formatting for different courses, but people that teach online, but that is something I would definitely look into to find out what you're going to get in your education. Very good questions. Thank you. Okay, let's move to the next slide. Now, medical decision making, again, that helps you in part look at your E&M for ProFee. But there's still other elements, and I've been talking about them. The HPI, history of present illness. This is where you're going to find out, and again, it's usually at the very top. You'll see what's the chief complaint. You know, a patient came in due to neck pain, and then the HPI will tell us when the neck pain started, you know, how severe is it? You know, what type of pain is it? Is it a sharp pain, a dull pain? Does anything alleviate the pain that you tried? What have you tried? What are you doing when you notice the pain, you know, the most? Is the pain there all day, or is it intermittent? Have you ever had a history of this type of pain before? Have you had an injury to your neck? And if so, what was done to treat it? Have you had any previous surgeries? Was this something that came on acute, or was this something that built up to the pain that level you've got now, where it was a little bit of an ache and then it just progressively got worse? You know, all that stuff's going to be in your HPI. Okay, and then some. Review of systems, the ROS. That's where we're going to they're going to look in your eyes, they're going to look in your ears, they're going to look in your throat, they're going to, you know, palpate your neck, they're going to feel for the glands, they're going to feel for the thyroid. We're going to palpate the bones in your neck, the cervical spine, to see, you know, is this a muscular pain? Is this a nerve pain? Is this a pain due to the bone? Maybe there's a herniation, or maybe you've got a compression fracture. You know, it could be several things. Maybe you have something to do with your thyroid, that it's enlarged and it's pushing on a nerve that's hurting your neck, things like that. So review of system. And then it's not just those systems. Again, we're looking at circulatory system, we're looking neurological, we're looking at the digestive system. They'll palpate the abdomen. What if they find, you know, they palpate your abdomen and your spleen is really sore for some reasons? Like, okay, why would your spleen be enlarged? Well, it's producing a lot of red blood cells. Why? What's going on? And why is it, you know, working so hard? Things like that. Also listening to the heart. How come I'm, you know, hearing a rapid heart rate? Your heart is working really hard, and come to find out your thyroid's enlarged, and so on and so forth. So this pain in your neck could ultimately be a problem with hyperthyroidism or something. The PFSH is the history component. It's personal, family, and social history. So again, with this, let's say personal history would be, have you injured your neck before? Yes, and I had a compression fracture in, you know, '08 because I was on the lake, and I was in a boat and we hit a wake and I got a small compression fracture of the neck, but that was way back in 2008. And you like how I just pulled this stuff out of the top of my head? Stuff I've seen before in documentation. But that's all been resolved. This doesn't really feel like that. This is something different. But you know, that would be personal history. And then family history. Yes, my mother had osteoporosis and my father had diabetes. Okay. Social history. I work full time, but I'm getting ready to retire. I'm married and I have 6 kids. And then, so all of that to answer, you know, all 3 components, personal, family, and social, that's a pretty, you know, detailed and or comprehensive, you know, that's a lot. And the physical exam, the PE, that's again, not the review of systems. That's where they're actually putting their hands on you and palpating. You know, review of systems is looking at the body systems, but the physical exam is actually hands-on. Okay, and each one of those areas will carry a component or an element that allows you to collect what we call bullets on. So if we have a really thorough history, because we get a personal, family, and social history, and we have a really detailed physical exam and HPI, you know, and our medical decision making is high, then again, a level, you know, then we could get a 4 or a 5 out of that. But on an established patient, if we don't get much of an HPI and we don't get, you know, any of the other things very high, we have to have at least 2 of the 3 to make a level. We have to meet or exceed. Okay. So again, each one of those is going to be covered in the E&M. Medical decision making really drives the elements. Again, I've kind of beat that into your heads, I think. But it all really depends on the documentation. Just like Whitney was saying, you know, the document, we cannot base something on assumptions or what we think the doctor was thinking. But the fact is often when you really get to know your doctor well, you know that stuff's in their head. You just need to make sure that they're documenting it. And so that's part of our role as the ProFee coder, is when you sit down with them saying, I know that you are really passionate about smoking and having your patients not smoke. And I see the documentation you're giving me. It's very thorough. You're covering a lot of components of that. However, to be able to use a code for that and to get reimbursed for all that work you're doing, all I need to know is it, you know, 3 minutes, 5 minutes? How much time did you spend to do it? And so with all of that documentation that you're giving me, just end it with 5 minutes in discussion regarding, you know, spent 5 minutes in discussion. You know, that's all you need. And so that's our job to help articulate that, because they may not know that that's a time-based code, even with the E&M and things. Now, again, there's a lot to do with ProFee coding, but a large component of it is the E&M. I want you to be mindful of some other things, especially if you're a student and you're doing your education, is that it can be based on interventions during like an ER stay. Okay, because ER E&Ms are a little bit different than the EMs that you use for, say, the podiatrist or the ENT. Okay, CMS gives some great information, but they don't really have a lot to tell you how to determine facility E&Ms. So again, we're not really talking about facility E&Ms, but I want you to know the difference between ProFee coding and facility. This was a great link that came with this article, so I went ahead and left it here instead of putting it down in the resource link. Let's talk about some of the modifiers that you need to be aware of if you're dealing with ProFee coding. Now, professional services will use ones like 21, prolonged evaluation and management services. So we had to be with this patient longer than normal, and so it was a prolonged E&M that was used. Unrelated E&M service by the same physician during a post-operative period. Okay, that'd be a 24. One of the ones that you use a whole lot with E&M is 25. Now, I didn't put that on here because, again, it's taught on a lot, but let's say your patient comes in for a sick visit, and the sick visit isn't because they're like sick to their stomach or they got sinus infection or pharyngitis or anything, but let's say they had a laceration on their hand, and you need and so you're going to stitch that up, and then you realize they haven't had their flu shot. It's time for their flu shot, and you end up giving them a flu shot as well. Okay, you're going to end up using a modifier 25 on that, right? Because you're doing more than was part of the one E&M. When you do your annual wellness visits or for Medicare, and a lot of times the provider doesn't, especially in rural areas, they will combine a sick visit with the annual wellness visit because they don't want to make the patient come back, right? And they need to treat for whatever reason that they're doing, or maybe they're going to give them their flu shots and their pneumonia shot at that time. Again, the annual wellness, that is an exam only. You can't do anything detailed work, as far as extra work for the patient. So you have to do an E&M, and then you have to let them know that why you're doing 2 visits at one time, and that is a modifier that lets you know that you're doing it. Let's say your patient comes in to the ENT and they're having trouble hearing, and they look, and sure enough, they've got bilateral cerumen impaction. Okay, so we're going to use a tool and clean those ears out. Well, that's an extra service that's being provided. It's a procedure that's being provided, so that's going to get a modifier as well. And these are things that are daily in all specialties. You're going to see anytime the provider does a procedure during the visit, you're going to append a modifier to that. And know that facilities, they don't report modifiers in the same type of modifiers that ProFee does. Post-operative periods are different. Whenever you look at a facility, they are going to have a different type of a global period, and the post-operative days for them are going to be 0, 10 days, or 90 days. So if you have a major surgery, let's say you have a hysterectomy, you're going to get a 90-day post-operative period there in that global. Let's say you, I think something simple that wouldn't be major surgery, I don't know for sure, but let's say you put tubes in the ears for a child. I think that may be just 10 days. I don't think it's 90 days. It would be something you need to go look, because I'm not for sure. I'm trying to think of something that would have a smaller global period. Maybe you can let me know. Give me an example of a 10-day global period that you would get post-operative. But facilities, they really they only have to be concerned with outpatient visits that occur on the same day. That's all. ProFee's a whole lot different. Let's look here at questions real quick. I'm planning on purchasing, oh, your online class. Before I do, I want to purchase my books. Can you please tell me on what author we're going to be using, or, oh, the info. If you send a message to the help desk, they can let you know. But also, we do have a link that tells you which textbooks and manuals that you can get for what course. So if you're going to take our PBC course, right now we use Carol Buck, and so you can get that off Amazon. And because, you know, never know, you could have an Amazon coupon or something, you know, get them real cheap. So absolutely send a message to helpdesk@cco.us and let them know which course that you're going to take, and they will get you linked up to the proper place. We really believe in getting the best price that you can for your manuals as well. AAPC puts manuals on sale all the time, or has bundled package. Check with them, or a bundle package that you might be able to get on Amazon. Thanks, Catherine, for asking that, and thank you for choosing us to take your course. Winnie, yeah, I have one doctor in particular that always bills a 99406 smoking cessation, and he's code, and spends 4 minutes. So one is like, it's like 3 to 10 minutes, and there's 2 codes, I think, that you can use. But if you do not document the time, then it doesn't matter how much time you spend, it still is not going to get, you're not going to be able to submit it because the documentation doesn't give you the information that you need. More on modifiers. So ProFee and facility, again, these only apply to hospital outpatient settings. Now, if you're going to do hospital outpatient versus outpatient, a lot of times they'll say, oh, I'm an outpatient coder. You would say ProFee coder, outpatient, depends what verbiage they use. But there's also hospital outpatient setting or facility outpatient, and they still use the CPT codes. Like when you go in and have a colonoscopy, you're not really using the hospital per se, you're using like the same day surgery, and it is part of the hospital. It's just it's under the wing of the hospital, but they use a different code set than if you were going to go in and have an ostomy put in. Okay, you know, because that's going to take major surgery, and you're going to be an inpatient, right? So again, those would still be different modifiers in hospital outpatient versus outpatient at the doctor's office. And another reason why you got to understand the basics in the ProFee. So a 73, let's see, discontinued outpatient procedure prior to anesthesia, and 74. So this is after anesthesia. These are 2 codes that when you're testing, you'll be tested on. I can pretty well say that you'll get questions on this, either in the modifier section of the CPC exam, or even the CCS. You'll need to know these. Or the COC if you're going to sit for that. Another one, professional fee, you'd report 52 or a 53. So you don't confuse a 73 and a 74 with 52 and 53. They're used in different places, but they sort of mean the same thing in a way. They're both discontinued or reduced services. Now, I'm not going to go into a lot of detail about these modifiers because we do education on modifiers, and that's another webinar. You can go check out our YouTube channel and you can see all, just type in modifiers. And we even have extra included in the course, but if you just need education on modifiers, we have a little mini course on modifiers that you can pick up, because modifiers is really something that people struggle with. Even I get confused and have to constantly go look up modifiers. And if you're doing ProFee, you're going to be involved with modifiers. So again, hospital would report 73 and 74, but your ProFee is going to use 52 and 53. Okay, so it's good to know those. Before we talk about the how productivity works and how to get better at productivity, I wanted to give you some other examples of things that you might want to be aware of in ProFee coding. And these are little notes that I give myself and when I'm going to be working with this type of coding. And you can't see my wall, but I have a whole wall of things like Z codes that are commonly used, because you never can memorize all the codes. Now, I felt like back when ICD-9 was around, I was pretty savvy, and those codes to me were a whole lot easier to kind of memorize. But they tell you, and a good instructor will tell you, you're not going to memorize codes. But let's say you're working for a podiatrist. Okay, that's a pretty narrow focus, right? It's only the foot. Some get additional training that can work on the ankle as well, but we're only looking at the foot, nothing, everything below the ankle. So the codes, the ICD codes, the E&M codes, the modifiers that are commonly going to be seen with a podiatrist, or even like an ENT, they're going to be doing ear lavages, they're going to scope, they're going to be doing tympanic testing and stuff. These are things that you'll see pretty repetitiously, so you'll get to know them well. However, if, say, you're working for a family practitioner, you're going to see a huge gamut of different codes, and you're not going to be able to have those in your head. So if you're a ProFee coder, you're probably going to have little notes all around, and I put them above my monitors. Another thing that ProFee coders do is you almost always have 2 monitors. I can't imagine doing production coding without having 2 monitors. I don't think you could do it. But as I look up at some of my notes, I'm looking at if you're doing, family practice, you might be doing nursing home visits as well. They have different E&M codes for established and new patients. So you may have a note for those. Medicare, when you get shots for Medicare, then you would use things like a Z23 for your diagnosis, because that's telling them that you're the payer, that you're coming in to have a shot. 90662 and G0008. Notice, and then there's codes for pneumonia the same way. Here's one that I learned the other day that I didn't know about, that I put a note up on my wall, and I'm excited to share with you. If you do a UA of 81003 and a drug test 80305, you need to append a modifier XU to that, to one of those, because there's no G code available for those. Preventative medicine E&Ms are different, and they're age-based. If you have to transport a UA, you use a 99000. Let's see, BMIs would be important. Let's see, these notes that I have, this pretty little blue one, you noticed I have some common Z codes that are on there for long-term insulin use, long-term oral diabetic, BKAs, AKAs, presence of artificial knee, O2 dependent. Then diabetes is something you might want to make yourself a little note like this, where you have diabetes divided up, because notice that 0.1 is keto, 0.2 is kidney, 0.3 is eyes, 0.4 is neuro, 5 is heart, and 6 is other. And that's just something I keep laying around. Now, after a while, you could probably have that memorized, but let's see, here is strep tests. If you do an 87804, that's 2 units. If you do an 87880, that's 1 unit. Medicaid will not pay for a 90460 administration. That's something as a ProFee, you're going to have to be aware of. Let's see. You have an EP modifier that you might have to append for Medicaid patients that are under 20. Here's one that you're going to see more and more of, guys, that who does not pay for consults. Now, we know Medicare doesn't pay for consults. Cigna just recently, last month, said that they weren't going to pay for consults, but UHC, VA, TRICARE, Cigna, and Medicare don't pay for consults. So that would be a 99242 if that code crossed your path. And these are all little things, you know. I got these on sale one time, and so I like to know. Oh, don't forget that the zoo codes that we look at, that the Z0.000 is without abnormal findings, and the 0.001 is with abnormal findings. And I made myself a little reminder of things like that. Capillary sticks versus venipunctures. When you know, a 36416 is a capillary. They just poke the finger. 36415 is a venipuncture. But did you know that if they do a venipuncture and a capillary, you know, they do two tests where they're going to do that, they're probably not going, you don't bill for the capillary stick, they just take some blood from the venipuncture to run the test. So again, you wouldn't put both of those down. But again, these are little things that you learn as you go with ProFee, because it's so diverse, especially if you're doing family practice. Let's see, what E&M range is categorized as sick visit? Well, when we say sick visit, we're meaning a 99211 through 99214. That your regular E&Ms, we just call it sick visit. But meaning there's something sick, the patient's sick for whatever reason, they have to do something. So that's kind of a layman's term, sick visit. It's not something you're going to see documented or in the E&M manual. Sorry about that. Let's see, Layla Princess, what do adjudication mean? Adjudication, oh, well, okay. Adjudication is like a validating of something. You know, what I would tell you to do is go Google adjudication, because you're going to find a lot of information about that. I remembered the first time I had to look it up. It was like, adjudication, why I keep seeing that? What are we doing an adjudication for? And in fact, we did a video, and I don't, it may even be on YouTube. It may just be in the club, but absolutely go look at that. Now let's wrap up really quickly about how to help with your productivity. As a new coder, you're going to be slow. If you change from one specialty to another, you're probably going to be slow, especially if you were to go from ENT to family practice, because they're going to be given shots all the time and doing strep tests. It's a whole lot of codes that you don't get, you know, generally. And production is something that they will pay attention to. In fact, I call it production coding. That's what I call ProFee, it's production coding. And when I did risk adjustment, it was, you know, productivity was very important. You had to be able to do, you know, 5 encounters an hour, or 5.5 an hour, which is not comparable to ProFee, because with ProFee, you're going to be doing like 10 to 20 an hour. And, you know, it goes even faster if the provider has already given you codes, whereas in the past, when things were, a lot of them were handwritten and stuff, there's no way that you did that many, and you had to, what I call, code from scratch. So there were no codes used. You put in the E&M, you put in, you know, you determined and looked up all of the diagnosis codes. Nowadays, the provider clicks those boxes, and they're in there in front of you. You're more or less auditing to make sure they've met the level of E&M, or that they've gotten their diagnosis code to the highest specificity, or they didn't miss a diagnosis code that they covered, you know, because again, they're not used to doing that. So production is important. You want to be fast, but even better, you want to be accurate. So you will be slow in the beginning, but every week you'll get faster. And especially if you're working with the same doctors. Unlike risk adjustment, you're never going to see or talk to these providers, and their documentation will always be different. They'll be all over the United States. So it's from scratch every time. Whereas, you know, if you're working for a clinic system, again, you may switch around and help other people, but for the most part, you usually assign providers, and then you get to know them well, and that way you get to know them and build that relationship with them because you're their translator. So how does it help you with productivity? Some tips: quiet, distraction-free work area. That's extremely important. You cannot do coding from your dining room table, even if you work from home and you're the only person that lives at your home. That is just, it's just, you're not going to do that. That's not going to be a good idea. You want to be able to have an area also, especially if you have a family, that you can lock the door. Large and multiple computer monitors. I think I have two 19s and I have two 22s, I think. Let's see, limit data on your EHR to minimize number of systems with information. So a lot of times you'll have your email in the background. You may have your encoder that you use. I like to use Find a Code whenever I do anything. And then you may have your system that will have your documentation on it, and then there'll be another system that you'll use to input the codes or change codes and stuff. So that's like 4 major things that you could be interacting back and forth, and so you'll get really good at being able to minimize and split screen things. You can do that on bigger monitors too, you know, so it just depends what works well for you. Also, just don't have things up that are going to be in the way. Also, I think I've heard people say you want to make sure that you have it big enough to where you can see it, so you're not doing this and trying to look from one page to another or anything. That'll slow you down. Limit keystrokes needed to complete tasks. You can put in some hotkeys sometimes on your keyboards. There are certain things that you don't need to do, like if you're writing notes and things, when you write, you don't write out modifier, you use, you know, a -25 to talk about that. So again, figure out ways to be effective, to where pretty soon you're just doing. When I worked in a pharmacy, I was so fast after so many years of doing the same thing. When I had the script in front of me and I'm putting the information into the system, and it was slower than I was, and I had memorized how many clicks and enters that I could do, and I would literally like find the patient, find the drug, you know, like 1, 2, 3, hit 0 twice, put in my, I had a brief, we had things that we can indicate, you know, if I put in TID, that's all I had to put in, and it would say take 3 tablets a day, you know, by mouth, whatever. So things like that. Update training and education availability quarterly. Hey, you know, take some extra training in modifiers, take some extra training in pathophysiology, take a compliance course to get some behind the scenes stuff maybe. Definitely, we have our medical terminology and anatomy. That's always great to do. Let's see, make resources available online. You don't want to have a bunch of books laying around you all the time. It's important. Let's see, Nancy says, if a provider performs a 99213 and a 9300 and the CCI says no bundling, do we still add the 25 modifier for ProFee? Yeah, you can't bundle them together. They have to be separated. Yeah. Yeah. So I wanted to show you this picture. This is a CCO person. It is not me. This person is much more organized. She sent me this today, and notice her little sticky notes and all the notes that she's got written there, so she could just glance at them and have her reminder. Whereas I like to use bigger cards, and then I will take them and put them on my wall above my monitor. She's got a highlighter there, but if you want to boost productivity, you want to make sure that your cat doesn't sit on your desk while you're working. I thought that was brilliant. I asked her if I could share this photo with you because I know a lot of people that have pets, and there's nothing like a cat. For some reason, they want to be right in front of you, sitting on your monitor. She actually has, I think, nope, that is, I started to say she has the same keyboard as I do, but mine's ergonomical, mine's split, but it looks very similar to that, where I have on the side, I have the numbers, you know, the 9 key or whatever you call that. And I don't even like the dog to be in the room with me because them making noises when you're doing production stuff. I wanted to verify I work for a primary care provider. Could we bill the symptoms like for bipolar instead of the bipolar? If you got a code for bipolar, you wouldn't code the signs and symptoms for ProFee. ProFee doesn't do signs and symptoms if you have a definitive diagnosis. And but if you're doing inpatient coding, you do. So yeah, you wouldn't do signs and symptoms, Joel. Yeah, that is one thing that you got to be very mindful of. So thank you guys, and I hope we didn't go over. Oh no, hey, we did. I knew we were getting close on time. And oh, thank you, Rondina. She was a student in the past. This is, again, just a kind of an overview of things you need to be aware of if you're going to go into ProFee coding. If you're a student, of course, this is the student webinar. Just heads up, these are things you want to be mindful of. We've done, you know, we'll probably talk about this again, and of course talk amongst yourselves, you know, in the social media, if you're on LinkedIn, Facebook, or YouTube. But if you're in the club, the CCO club, absolutely share with everybody what works best for you, what you're concerned about, what you think is going to be problematic for you, and see if anybody can give you some tips. Maybe you want to know, you know, do you use colored index cards or white index cards? Do you use sticky notes versus whatever? What E&M tool do you like to use? Do you have to get readers, or what do you do to make your screen bigger or smaller? What size monitor should I get for external monitors? Now, if you work for somebody, a lot of times, especially like clinic systems and things, they'll give you a computer, not always a laptop, sometimes a laptop and an external monitor, okay, or a computer with 2 external monitors. That's pretty common. You know, more so now than ever before, coders work remote in ProFee. It's not always, but more so than before, because it's cheaper for the system, the hospital system or the clinic system, to send you home, and everybody talks on email, and you can get a chat system or something like that, and they come in and meet with their providers or have meetings and things. You can go to webinar. So you know, you may want to think about making sure you have a good office space, or if you go in for an interview, ask them, you know, do you work in-house or do you work remote? And if you're in-house, will there be a time when you think you're going to make your coders remote? And so on and so forth. So, because people that have trouble getting around, mobility, you can still work from home pretty easily. It might be harder for you to go in and work in an office, though. Yeah. Okay. All right, guys. So really appreciate it. Make comments. If this was helpful, it will be in the club. You won't be able to share this, but share cco.us with everybody and let them know, share our YouTube channel or our Facebook page. And now we're on LinkedIn because they're doing live webinars. And since we're good at that, we're doing that. So share with everybody on LinkedIn. All right. Thank you, guys. And again, your resources links are back there, so you can get those if you're in the club. Have a great night, guys.